Hi everyone, my name is Maulud and welcome to another talk in a seminar ETM department for winter 2021. I'm glad today we have our guest speaker, Dr. Uh, Brent, and he's a chief strategic for Noble strategic start company here in Portland. And this start company focus on innovation risk adjustment and giving a solution for a healthcare organization. He has like an experience over 37 years in the mid-care and risk adjustment, and he hold his PhD in system science engineering management and master degree in software engineering. With further that, I'm gonna pass it to Dr. Brent to introduce himself and also start his presentation.
Thank you. So let me get squared away here. Okay. Hi, my name is Brent Zenobia. I am an alumni of the ETM program. Graduated with my PhD in, 2008. And I know Dr. Jetter, but I think most of, if not all of the rest of you are new faces for me. One of the things I wanted to do here was, I'm certainly going to go through the presentation, but it also occurred to me this would be a useful opportunity to talk about how you can use your degree, because I know in the PICMET conference, one of the things they do is they take the students aside and they have an opportunity to talk to an alumni about how you might be able to use your degree once you're done with the ETM program. And this presentation that I'm going to give you is a pretty good example of that. So let me give you a little context about this. I work for Novilus, as I said, I'm chief strategist for that company. We have a kind of a side hustle, which is doing consulting for different health insurance companies across the country. And I was pulled in to do, we already had a consulting contract with Blue Cross and Blue Shield of Tennessee on a different topic. And while we were in the course of working on that, they asked if we had anyone who was knowledgeable about some major changes that they had heard about that were going to be starting to come into effect the beginning of this year. This was last June when I gave this presentation. I had less than a week to pull it together. I had a really rudimentary knowledge of the subject because of a conference I had attended at MIT, and the whole thing had to be done within 20 billable hours. So what I want to do is I want to show you how to pull together a quick high-level summary, and this was to the chief executives of Blue Cross and Blue Shield of Tennessee, how you can leverage your degree to engage in consulting opportunities. And I'll give you an example, through this talk of the kind of deliverable that you might be asked to do as a consultant, okay? So the subject that they had asked for was something called Blue Button 2.0. Now, I'd have to wind up a little bit and tell you the reason why I was asked to do this is because I knew what Blue Button 1.0 was. So Blue Button 1.0 was, the broader context for all of this is really healthcare interoperability. This has been a very hot topic in the healthcare industry for many years. The crux of the problem in the U.S. healthcare industry is that when you go into the doctor and you tell your doctor what your problems are and they enter those in a medical record, those medical records are not very easy to move from your provider to your insurance company or from one provider to another. And there's been a great deal of attention and a lot of legislation and a lot of funding that has been thrown at this problem for many years to try to figure out how can we make these healthcare records more interoperable, while at the same time safeguarding people's privacy and making sure that the records are secure and not vulnerable to hackers. Enter Blue Button 1.0. So Blue Button 1.0 came out in, as I said, 2011. It was a moderate success. It was not a huge success because it required the user to do too many things. So at the end of 2016, Congress passed a new law called the 21st Century Cures Act. And one of the things that this law required is it put a bunch of legal requirements in for that required healthcare insurers, doctors, hospitals, basically everyone in the healthcare industry were required to implement certain interoperability standards, and it gave the time frame as to when these had to be done. One of these is something called Blue Button 2.0, and I have to talk about what CMS is, because that's another thing about this, is that the executives that I was delivering this to in Blue Cross Blue Shield of Tennessee would know a lot of this information. So when I did the presentation for them, I didn't want to belabor that point, but CMS is the Center for Medicare and Medicaid Services. They are responsible for administering all of the Medicare and Medicaid programs in the United States. And they are truly the 800-pound gorilla of the U.S. healthcare industry. So when Medicare says it's going to do something, everyone pays attention, because one way or another, almost everyone in the U.S. healthcare system is impacted by the decisions that are made by CMS. So when CMS said, we're going to take another go at Blue Button, and we're going to do Blue Button 2.0 based on more up-to-date technical standards, that was a big deal in the industry. So this is the reason why the executives of Blue Cross and Blue Shield wanted me to explain to them what was going on, because they had not heard about this before. All they had heard was CMS is going to start requiring this, and they had heard some vague rumblings that there were some legal requirements that they were going to have to implement. So that was the purpose of the presentation, was to provide them this context. So what Blue Button 2.0 is it's an API that would allow anyone who is in the Medicare program, and Medicare is anyone who is over the age of 65 plus people who are disabled. It would allow any of those beneficiaries to be able to retrieve their health records from any doctor or any insurance company via these third-party apps. So you would go to Google Play, for example, and you would pick your favorite third-party app, download it, and then from your phone, you would be able to have that app retrieve all of your medical records from anyone that you have seen. This was announced in March 2018. I won't go into too much about it. You will hear a lot about HL7 FHIR. This is the technical standard in which the API is implemented. OAuth 2.0 is something they borrowed from the banking industry to ensure that those records would be secure. So it's important to understand that this is not happening in an isolated manner. Blue Button 2.0 is just the tip of the iceberg on a huge transformation that is occurring in the healthcare industry. So I need to talk about the broader movement within which Blue Button 2.0 is taking place. So as I mentioned, there is this law that Congress passed called the 21st Century Cures Act. And it's much broader than just Blue Button. I will go into the requirements for that act in a few slides, but this gives you a sense of some of the players that are involved in this movement. Now, I've already discussed Blue Button, and I've discussed who the Center for Medicare and Medicaid Services is. The Karen Alliance, that is a consortium of a number of firms, including Apple and Microsoft, who are coming up with the technical standards for implementing Blue Button. HL7 Fire, I mentioned, that is the actual protocol that is being used to exchange some of this stuff. The Vinci Project is a big deal. This is actually the conference that I attended at MIT was for the Vinci Project, and I'll talk about that in a minute. The Sequoia Project is sponsored by what's called the ONC, which is this is the ONC, that is the National Coordinator for Health Information Technology. So the ONC is the U.S. federal government entity that sets all of the healthcare technical standards for the United States. And the Sequoia Project is one part of what's going on there. And then HIMSS is a Health Information Management Systems Society that is an international society principally of a bunch of IT people in the healthcare field. So these and many other entities are working on the broader topic of healthcare interoperability, of which Blue Button 2.0 is just one piece, okay? So one thing that's always very helpful is to come up with some kind of a glossary, because that can help your clients to be able to follow up, for example. So all of these are hyperlinks. You can click on any of them and get to the particular entity or the definition. But just to walk you through some of the very basic concepts here. EHI, I'll use that a lot. That is simply electronic health information. So, that's a pretty broad brush. That can include medical claims, pharmacy claims, lab data, benefits data, pharmacy formularies, you name it. So it is your health information in electronic form. An HIE is called a Health Information Exchange. I don't know if any of you have been in had to deal with the COVID vaccination. Probably not many of you, but when you go to get vaccinated in the state of Oregon, they ask you to sign up with what's called I think it's called My Legacy. It is an electronic health information exchange maintained by the state of Oregon that is used to exchange medical information between, say, a hospital and a doctor, or a doctor and the health insurance company. So, and there are many HIEs out there in the country. Each state generally has its own, and I won't go into a lot of detail, but that is part of this interoperability movement of being able to move these records around. HL7, I mentioned before, the reason it's called HL stands for hospital language. It is the electronic language that is used to exchange information between different entities in the healthcare system. FHIR is a framework that sits on top of HL7, which actually structures the data in a form that you can actually do something with it. The Vinci Project, I'll talk about in a minute. I already mentioned OAuth 2.0, the ONC, some of these other things, TEFCA, the US CDI. These are all major initiatives that have been underway for the last 5 or 6 years to solve this problem of how do you move medical information around, which is a huge, huge deal. The United States healthcare industry is 1/5 of the U.S. economy, somewhere between 1/5 and 1/6. So you can imagine the magnitude of the problem that is involved in rolling out these technical changes to such a huge segment of the U.S. economy. Okay. So now I was going to talk about a little bit about the Da Vinci Project. The Da Vinci Project is one piece of this interoperability puzzle. And the reason that I'm talking about Da Vinci is because I want to give you an example of how groups come together to work on interoperability. So the Da Vinci Project, this is the conference that I attended in spring 2018, which is kind of what was the jumping off point for me doing this presentation for Blue Cross of Tennessee. So what the Da Vinci Project is a collaborative effort, and there are healthcare insurance companies, there are doctors and hospitals, there are what are called EHR vendors, or the companies that keep track of the medical records on behalf of the doctors and hospitals in the United States. Some of those are very big players. So all of those different organizations, companies, you name it, they come together periodically to develop what are called use cases. So these use cases are around specific they're around specific kinds of problems that have to be solved in order to get the data from one place to another. For example, let me pick an example here. So coverage requirements. So coverage requirements are when you go to the doctor, you will have you will have typically in the United States you will have your healthcare insurance from some carrier, let's say Blue Cross. And Blue Cross is going to provide you with a certain kind of coverage. They're going to say, okay, you're for pregnancy, here's what your coverage is, here's your benefits, here's what your copay is, all these different insurance terms. It's basically, this is the coverage that the insurance company has agreed to provide for you. So when you go into the doctor needs to know what's covered by your insurance and what's not. So part of that is what's called coverage requirements discovery. So there is an electronic information exchange that has to occur between your doctor and the insurance company, or between the hospital and the insurance company, so they know what your insurance coverage is going to be. So what this use case is how does that exchange work? Another would be what's called prior authorization. So let's say you snore, and you need to go see a sleep doctor to do something about the fact that you are snoring. So that may require, depending on your insurance may have to okay that before you can go have an overnight sleep study, or before the doctor is going to give you a CPAP machine to address your snoring. That's what prior authorization is. So once again, there is an information exchange that has to happen so that prior authorization works correctly. So the way this works is you can almost kind of think of it, you're familiar with the term apathon. That's kind of how this works. So you have 60 or 70 representatives of insurance companies, big provider groups, different vendors are all together in this conference. And you break up into sessions and you vote which of these different applications that you are personally interested in. The ones that I was involved in were gaps in care and information and chronic illness documentation for risk adjustment. So you will, out of that, group of, 60 to 100 people, you will break up and you'll sit in these individual tables of other people who are interested in that topic. So for the gaps in care and information, I think there were 2 of us from healthcare insurance companies. There was 1 person who was a doctor, and there were, I think, 3 or 4 people who were from different vendors who produce products in this space. And what we did is we walked through, well, what is our business need? And then there is this structured process that you go through to flesh this out and say, well, what do you mean by gaps in care? And you have to go through your definitions. You have to identify what kind of information needs to be exchanged. So by the time you are done with that 2-day session, you have an outline that tells you kind of in general terms what the business requirement needs to be for that. Then everybody goes home, and over the course of the next few months, you collaborate remotely on this so that it's becoming more and more refined. And there is this process that you go through. Discovery is for things that are in the most basic level, that initial sitting around the table, that's called discovery. In build is when the requirements are solid enough that the technical people can start working on them. And this is really and we're still in the process of developing the technical requirements and exactly how this problem is going to be solved from a software standpoint. Then there's a voting process, which determines basically, is this ready for prime time yet? So depending on the results of that ballot, you may stay there, or you may have to do some more refinement, or there is this reconciliation process where what you're essentially doing is building a consensus among all of these different players in the industry, and then finally is promoted, and you're ready for prime time. So you can imagine, this is just one piece of all the different problems and activities that take place within the healthcare space. So everything down to how do I get an oxygen tank at my home, or how does the health insurance company inform the doctors who needs to have a breast cancer screening, who needs to have a colorectal cancer screening, and then when they go do those screenings, how do they return the information back to the insurance company or anyone else who wants to have that information? So you can imagine, given the complexity of the healthcare system, the sheer size of the problems that have to be solved. And that's the reason why these things are taken in bite-sized chunks that are really driven by the people who are most interested in solving that particular problem. But that is what the Da Vinci Project is about. And as I said, it's a very big deal. But it kind of got interrupted by COVID, because it only started, they only started getting involvement from people in the business in that conference in spring 2018. Prior to then, the only people who had worked on Da Vinci were people who were highly technical and knew the internal details of the HL7 fire standard, which all of this stuff sits on top of. So starting in the spring of 2018, they realized that, well, maybe it wasn't such a good idea for them to get too far along trying to develop the technical underpinnings for this thing without actually talking to the subject matter experts in healthcare who knew the ins and outs, for example, of how to do clinical exchange, data exchange, or payer data exchange. So that's how I got tapped to go there, is because I was sent to represent Cambia Health Solutions, which is literally across the street from the ETM offices, and it represents Blue Cross and Blue Shield plans in 4 northwestern states: Oregon, Washington, Idaho, and Utah. So I was asked to go represent the company at this Da Vinci conference for the first time that anybody from the business was going. So anyway, that's kind of gives you a flavor of how the healthcare industry is working on this interoperability problem, is to look at these very practical kinds of problems and go through this, frankly, kind of lengthy process of saying, well, okay, interoperability, it sounds great on paper, but how is it actually going to work? Well, this is how it works. Now, CMS has been paying close attention to this, and every year CMS comes out with what's called a call letter, which announces all of their rules changes that are going to be implemented during the coming year. And in their call year 2020, which was last February, they indicated that these 2 Da Vinci use cases that have the arrow are going to become a requirement for anyone who, any healthcare insurer or any provider who accepts Medicare or Medicaid funds, which is practically everyone. So that they put the force of government mandate behind this, which up until then had been the real problem, because until CMS said that, well, all this stuff is great, from a technical standpoint, but the problem is who's going to pay for it? That was something that I kept asking people, and people kept saying, well, who knows? Just keep working on the technical stuff. Well, CMS solved that problem of who's going to pay for it, and the answer is you are. You being everyone, every company who operates in the healthcare industry is just going to have to suck it up and develop this because or else, that's kind of how CMS goes. They issue these mandates, and you have to do them. That's sort of the dirty little secret of the U.S. healthcare industry, which is that through the miracle of government regulation, the government has effectively vastly extended its unpaid workforce, and has enlisted every company and every doctor, every hospital in the healthcare industry, and has said, well, okay, you gotta dance to our tune, and we're not going to pay you for it. You just have to do it if you want to stay in the game. So this has the effect of giving the government a great deal of leverage without necessarily having to pay for it, because you as an insurance company are not compensated for this. So these were the use cases for Blue Button 2.0, and there were 4 of them initially. One, let's say you are a research organization and you are doing a clinical trial. You need to be able to populate the medication list for that trial. Okay. The second one was, if you are a PCP, is primary care physician, that is to say your home doctor, so to speak. That's your primary doctor. A PCP can access, if you are a patient, the PCP can access your other healthcare data, for example, anything behavioral health, to better inform your treatment. Because in today's world, let's say you have Dr. Jeter, who is your main doctor, but you also went to go see Dr. Weber, because you were having some issues with depression. Well, Dr. Jeter wouldn't be able to see anything that Dr. Weber was doing, because behavioral health is walled off from the rest of the healthcare system. So the purpose of this use case is to sort of burrow through that wall. Third one is okay, so let's say you have diabetes or hypertension or cholesterol, high cholesterol. I should say, your doctor may prescribe some medication that is intended to remedy those conditions. Let's say it's cholesterol. So you might be on statins to get your cholesterol down. There is a measure called medication adherence, which basically amounts to people are watching to see whether or not you are actually taking your drugs. I mean, they can't verify that you are actually taking them on a day-by-day basis, but they can monitor whether or not you are getting your prescriptions refilled in the time that you would expect them to be filled. And the medication adherence is one of those measures. What it requires is if you, over the course of the entire period that you are taking that medication during the year, let's say you start on January 1st, from January 1st to December 31st, you need to be covered by a prescription for 80% of that time. If you started on March 1st, then from March 1st to December 31st, you would have to be covered by a prescription for 80% of that time. That's what medication adherence is about. So what this use case is the pharmacy wants to see that information because otherwise they're kind of blind to it. That there are other entities in the healthcare system that have information about that medication adherence, but the retail pharmacy isn't one of them. So that was the purpose of this use case. And then finally, there is a lot going on in the healthcare system for any given individual. You may see, particularly if you are in Medicare, you may have 5 or 6 doctors. You might have a primary care physician. You might have a cardiologist, a nephrologist. There might be, what do you call it? Not behavioral, but I'll draw a blank on it. But there are lots of specialists that you may end up seeing depending on what your particular healthcare condition is. And you've got lots of prescriptions, and you've had hospital visits, and you may be getting what do you call it? Follow-up visits. So that's a lot to keep track of when you're 80 years old. So then the fourth example of the blue button use case, it pulls all of this data into a single dashboard so that you can see in principle everything that's going on for you, that you got this colorectal cancer screening is due on this date, your breast cancer screening is due on that date, here's what your medication adherence is doing, et cetera, et cetera, et cetera. So those are the 4 use cases for Blue Button 2.0. The bombshell came on March 9th of last year. So this is when, and then there was a follow-up at the end of April of last year. And these are the interoperability mandates. This is what has turned the industry upside down because these are legal requirements that everyone in the healthcare industry is required to conform to. The first one, by January 1st of this year, anyone who in the industry who has received money from Medicare Advantage, Medicaid, or CHIP, which is Children's Health something or other program, it's a children's health program, have to implement this HL7 FHIR API so that patients can easily access their information via these third-party apps of the kind of thing I was talking about where you download from Google Play. So that gave people 9 months from the time the mandate was announced to stand up all of these APIs so that any of that healthcare information would be available. Now, they have delayed enforcement of several of these. They gave us an additional 6 months. So they haven't changed. This is still the mandate date. They're just saying they're not going to enforce it until beginning July 1st of this year. The second is the provider directory. So in today's world, provider information is very piecemeal. For example, let's say you go to the Very Friendly Clinic. The Very Friendly Clinic has got an address, it's got contact people, it's got doctors who are there. Those doctors have different accreditation, et cetera, et cetera, et cetera. And when you are when you get Medicare and you are contracting with an insurance company to do Medicare Advantage, which is a private insurance-run version of the Medicare program, there are a lot of requirements on those insurance companies, and one of them is that they have to keep their provider information up to date. So when you are deciding which of 5 or 6 possible insurance companies you might want to receive your Medicare through, you need to be able to look at which doctors are there and is my doctor covered under this insurance program. And one of the problems that the industry has had is that information gets stale and it's very hard to keep up to date. So what this mandate does is says by January 1st of this year, anyone who provides insurance involving Medicare Advantage or Medicaid or CHIP must make that provider information available via an API. So they now have to keep the information up to date. And again, that information has to be available in an electronic form. Again, their enforcement has been delayed to July. ADT notifications. This has been a chronic problem in the industry. And ADT is a hospital admission, discharge, or transfer. So it is a notification that somebody has been admitted to the hospital or discharged from the hospital or transferred from one hospital to another. And the reason this is a big deal is because there are a number of requirements that have to be met within 30 days of you being discharged from the hospital, or sometimes as quick as 7 days from being discharged from the hospital. For example, if you're discharged from the hospital in the Medicare program, they are required to do a medication review within 31 days. And that medication review is designed to make sure that they have not prescribed something that's going to kill you, because you may be under medications that the hospital didn't know about, and they may accidentally double up the drugs that you're supposed to do. So somebody, actually your primary doctor, needs to go through your medication list after you're discharged from the hospital to make sure that nothing dangerous has been prescribed to you. In order for them to be able to do that, your doctor needs to know that you were even in the hospital to begin with, and that's been a big problem. So by January 1st, all of the hospitals for Medicare and Medicaid have to be able to send out these electronic ADTs. Again, enforcement's delayed. Payer-to-payer data exchange. This is, let's say I have the very big insurance company, and I've decided I don't like the very big insurance company, and I want to switch my coverage to the small, tiny insurance company. Well, one of the problems there is that the tiny insurance company needs to have all of my records from when I was with very big and tiny don't talk to each other. So this mandate says by January 1st of next year, all of the insurance companies have to be able to exchange patient data through this US CDI clinical data standard. So this allows your medical records to move when you switch from one insurance company to another. Public reporting and information blocking. So in today's world, when you go to the doctor, you will notice that the doctor is entering a lot of information into the computer. That computer system is called an EHR system, or an electronic health record system. And there are a lot of vendors in the EHR space, but the biggest one is called Epic. Epic contracts with most of the hospitals in the United States, and there are a lot of doctors who are attached to hospitals because most of the time they see patients, it's in a hospital setting. So that means that all of those clinics that are associated with the hospital are also on Epic. This gives Epic a great deal of power because Epic will not permit anyone to have the medical records that are on their systems. So if, let's say, you were a clinic and you decided you wanted to tell Epic to go pound sand, you were gonna switch to Allscripts or Cerner or one of the other companies or Athena that are big EHR systems. Epic would say, well, I'm really sorry to see you go. Lots of luck. And at which point you say, well, oh, by the way, I need to transfer all of the medical records from my patient from Epic into the new Cerner system. And Epic says, well, good luck with that because we're not required to assist you. And oh, by the way, this is our intellectual property and you can't have it. And if you try to move it or if you try to do a screen grab, we'll sue you. That's called information blocking. And it's been a major reason why Epic is a huge force in the industry. So the requirement here is that as of November 2nd, 2020, for the 2019 year, it's now illegal for clinics and hospitals or any other entities that may be engaging in information blocking can be fined. So a CMP is called a civil monetary penalty. And they had not, at the time that I did this, decided on what it's going to be, but they were talking about $1 million per violation. And what exactly information blocking is was still to be decided. So there was a huge potential fine for something that nobody quite knew what they were going to be fined for, and it was going to start in November of last year. So this got a lot of people's attention, and this is actually one of the biggest areas right now is are all the software engineers trying to make sure that they are not accidentally engaging in information blocking. And then finally, digital contact information. This is kind of the flip side of this provider directory one. The provider directory mandate is aimed at the insurance companies. The digital contact information is kind of analogous, but it's actually aimed at the doctors, making sure that the doctors and the hospitals and the clinics are keeping their information up to date. So that's a lot. And it has caused a lot of reaction. So everyone agrees that interoperability is a good thing, but there were a lot of people who were taken aback about how quickly this was being rolled out because the healthcare industry is used to having changes more in the way of years rather than months. So the EHR vendors, particularly Epic, really hit the that they were really strongly opposed to it. Epic announced that it was going to sue to enforce its intellectual property. It has since backed down from that position because it kind of looked bad for business. But they are not very happy, and the reason is because they're no fools. They know that these interoperability changes are going to have a huge effect on their business model because the EHR companies have been taking a great deal of advantage to the fact that they are sitting on top of a gold mine of health information that nobody else can have. and they're basically jealously guarding the power that derives from this information that they're sitting on. The provider vendors, these are companies that sell products and services to hospitals and clinics. Their concern is they're taking a look at that Vinci thing that I was showing you earlier, saying, hey, this is going to take a long time for us to get this done, because everybody's been working on Vinci on the corner of their desk. And then now suddenly you're saying this is going to be the law and you have to turn this thing on by January of this year. Also, not everybody has been involved in the development of Vinci. I mean, you think about it. Let's say that, for example, that conference I was in 2018, if you got 100 people sitting around the table, well, there are hundreds of thousands of people in the healthcare insurance industry. And why should those 100 people that were sitting around that table know very much about the particular neck of the woods that a given provider is in? Some providers who are specialty, for example, the difference between, say, a dental claim and an eye care claim, a vision claim. Obviously you've got some pretty special requirements on a dental claim. Dental claims are pages and pages and pages of diagrams of teeth. And you have to say specifically, out of these, whatever, 32 teeth or however many you have as a baby, where on the tooth was this? And so, and then, what's that got to do with somebody who is, an ophthalmologist who's talking about your eyes and saying, okay, well, I care about, getting the information that is relevant to your eyes. So why should, this small group of people that's been sitting around these tables know anything about my particular area of medicine? Which is a valid point. AHIP is the insurance lobbying group, America's Health Insurance Plans. They said, basically, you're not giving us very much time to absorb this. This is really complex. The standards are immature. And most tellingly, those third-party apps that would be downloaded through Google Play, there is no certification process for those. Just groove on that for a minute. So what the AHIP is saying is, CMS, you need to slow down, and we need to make sure that we're not about to jump the track here. AHA, AMA, AMGA, and MGMA, that is the American Hospital Association, the American Medical Association, the American Medical Group Association, and the Medical Group Management Association, they were throwing a fit about the privacy safeguards. They're saying that this is basically going to be a hacker's delight. It's going to expose the providers to liability. It could be turned into a terrible weapon aimed at the providers for something called a RAC audit that I won't get into. So the concern here is that by making the data interoperable without putting in adequate safeguards to determine whether the data was good in the first place, what's happened is that you have created the ability to move bad data around without, the problem is, okay, suppose you get bad data in the system, and now you're making it easy to move that bad data from one place to another. How do you ever fix it? Where do you go in the system to say, okay, well, this data is inaccurate, we need to go fix it? But it's like whack-a-mole. It's all over the place, right? And the others are basically similar. HIMSS is saying this shouldn't be used as a sledgehammer. Other people saying it's moving too fast, except of course Apple and Microsoft, who are saying, oh, this is just the greatest thing since sliced bread. We need more, and we need it sooner, because of course they want to enter the healthcare industry, and this gives them a leg up and solves certain problems that they otherwise would have had in penetrating the industry. Other payers are saying, you know, this is inevitable. We'll just make this mandatory for everybody. So I want to talk about what this is going to do to the healthcare industry. Now, this is a form of network analysis that I picked up from David Krackhart of Carnegie Mellon University. Very interesting. What you do is you identify who are the major players in the industry and what is it that is flowing between those players. Now, one way of doing that would, typically, that's the kind of thing that if you had an interpersonal, if what you were doing was graphing people rather than industry players, it would be like there's a trust network, which is who trusts who, or there's an advice network about who is giving advice to who. But when you're looking at an industry, what you might want to look at is a revenue network, which is how is money flowing between the players in the industry. So that's what I put together is the federal government is the payer of resort. There is money flowing from them to the providers, money flowing from them to the insurance companies. The insurance companies are paying claims submitted by the providers, so there's money flowing from the payers to the providers. These are the computer systems that the providers are using, so the providers are paying these vendors. The patient, which is you, are contracting with your insurance company, so you're paying them through premiums. You are also going to the pharmacy to get your drugs, and that is going to what's called a PBM, or a pharmacy benefits manager. The payers contract with the pharmacy benefits manager, so there's money flowing there. And then these are the pharmaceutical companies who are developing the drugs. They are being paid by the PBMs. Okay. So the power really is who is sitting on top of the locked up information. That's the double lines here. So the payers have got information trapped. The EHR vendors have got the information trapped. The PBM vendors have got the information trapped. So this is information blocking. When these interoperability changes, however, you see that the power relationships in the industry will change dramatically. Those entities who previously had been sitting on top of that locked up information, the insurance companies, the EHR vendors, and the PBMs become less powerful because they can no longer block that information. And what becomes very important now are healthcare analytics vendors, because it will be possible for them to hoover up information on people's healthcare records and do marketing accordingly. So I don't have a lot of time left, so I'm not unfortunately going to be able to go into too much detail about these shifts, but it is a huge shift that is about to happen in the next 3 to 5 years in the healthcare industry, because those current players who have a lot of power because they control healthcare records, they're going to lose a lot of that power, and other players who are currently minor are going to gain a lot of power because they'll be able to apply big data analytics to it. So moving along, I'm just going to have to brush over some of this kind of quickly so we can get through this. One of the problems here is we have already seen some security problems, because there was a breach in Blue Button that affected 10,000 people in a test group. And these third-party app developers, the ones I was talking about that you download from Google Play, they are not what is called a HIPAA-covered entity, which means they are not bound by the same laws that protect your healthcare data that a doctor or an insurance company would. They are free to sell your healthcare information to the highest bidder. And a lot of people who are going to be downloading those apps are not going to understand that they are handing these third-party app developers the keys to the kingdom. There is also no certification process for them. So there's also some political dimensions. So you can begin to understand what's going on here when you start seeing who it was that was pushing these regulations to be basically expedited. It's no accident that they would take effect in January 1st, 2020, because Jared Kushner was looking for a political win for the Trump administration. And you see some of the statements that have been made by some of the key players here in pushing out these very aggressive regulations has been a very free market philosophy that is behind them. So anyway, there is a real risk here that in rolling these out very quickly, there are a number of potential problems that are basically being shoved under the rug in order to get this stuff out as quickly as possible. So finally, I ended my presentation for the board in Tennessee by recommending some follow-up steps, mainly around assessments of readiness and that sort of thing. I don't need to go into those now, but it's always worth doing that at the end of a consulting gig to be able to peddle your wares. But I'm going to stop at this point, and I am going to throw the floor open for questions. I think I'm supposed to use that one. Yes.
Okay. Thank you so much for your talk. So I'm gonna give a permission for people, they can unmute themselves and they can ask the question, or you can use the chat also. The first thing, like some of the people they asking about the presentation. Can I send them like the presentation?
Yes, of course.
Okay, thank you.
So what are some of the top healthcare analytic companies to pay attention to? There are some obscure names. One would be Amazon, another one would be Google, another would be Apple. They want that data and they want it bad. They have the resources and the depth to be able to do that kind of big analytics work. So, and some of them, you know, you will not have heard of because they don't exist yet. But certainly, also the EHR vendors will be trying to get into that big data analytics space in a major way, because they don't want to lose their relevancy and they don't want to give up their power, and they know what a threat this represents to them. But one of the biggest beneficiaries of this are going to be pharmaceutical companies, because what they'll be able to do is, you know, in today's world, when you watch daytime television and it's just, you know, in the breaks between the soap operas, it's just one drug commercial after another. They'll be able to target that much more specifically to you, because they will have your medical records and they will know what kind of drugs, you know, potentially you would benefit from. In fact, there is a risk that they might try to bypass doctors entirely and just market those drugs straight to the consumer. So we'll see what happens there. Clinical informaticist. Can you? I don't know if people can come off mute, but what you mean by an informaticist?
Well, I guess that's kind of part of the question. Clinical informatics is the science of storing, using, interpreting biomedical data. American
okay.
Medical and yeah.
Right. Okay, I understand. Yeah, so there's sort of two pieces of that. One would be the data science piece, and that is really those people typically work with the actuaries they're crunching and grinding on the medical record to determine the relative prevalence of certain medical conditions within populations of interest. So there is that. There is, I mean, the healthcare industry is just so huge that, that there's not a corner of it that is not going to be affected by this. And then the clinical informatics, if I understand who you're referring to, this would be like research scientists who are, they are interested in getting access to those healthcare records because they can be very useful during clinical trials and then in the development of medication and new treatments. So there's definitely a lot of benefit. This will benefit a lot of people to be able to have this information, freely exchanged. Where the downside is that it's also going to cause a lot of disruption. So if you are an existing vendor in the healthcare industry, you really need to be on your toes because you could find yourself with your entire business model undermined within a couple of years. It's definitely a disruptive innovation. Other questions?
I think there's another question in the chat. They asking, can you talk about the role of the clinic informatics?
Oh, that's the one I just addressed.
Oh, okay.
Any other questions, comments? Does it increase the healthcare market size? I think it does because it is going to make it easier for new competitors to enter the market. As I said, Google, Amazon, Microsoft, Apple, all of them have really wanted to get into this space. And one of the big problems and the reason why it has been difficult for them to enter the space, aside from the fact that they don't know anything about it, is because they lack the data. So if you are developing a new application for healthcare, you need to be able to test that application on real world healthcare data. And they don't have access to any because in today's world, that data is locked up in the EHR systems, in the insurance company systems, in the pharmacy benefits manager systems. So you really have to partner with them to be able to get access to that crucial data so that you can develop new products and services. And this interoperability will make it easier for new competitors to enter the market for that reason. Yeah, absolutely. For the last one about the information as an infrastructure, and yeah, patients should have control over their data, but bear in mind that the patients we are talking about are elderly, and they are vulnerable, and it's not a good or bad thing. It's a good and bad thing. Because on the one hand, yes, this is definitely going to be an engine for innovation and is going to cause a lot of maybe productive churn in the industry. But on the other hand, there are a lot of vulnerable people who just want to be left alone and do not have the cognitive resources anymore to be able to absorb what is about to happen to them. And that is a definite concern, and it's particularly a concern among the doctors because their allegiance is principally to the patient. And they're asking the hard question about, yeah, this may benefit a bunch of vendors and other wealthy or at least well-resourced entities within the healthcare industry, but who's actually looking out for the patient's best interest. And with that, I think we probably better call it time. So I hope you enjoyed the presentation today. I certainly enjoyed the opportunity to share it with you. Thank you very much.
Thank you so much, Dr. Brent.
Thank you, Brent. At this